I got involved with the patient safety movement about 7 years ago as a result of my late husband's avoidable death. My husband died in a small community hospital.
3, 2, 1, 0. All engines running. Commit. Liftoff.
My husband was a former astronaut. He flew 4 flights in space, including the second landing on the moon. And so he had spent his whole life in very complex, high-performance systems that were built for safety, and yet he died a preventable death from a system failure.
If safety is a system issue, then we need to find a way for there to be a clear responsibility for the improvement of safety in our system. And I think many people are talking about this now, but it's actually very difficult to do. It's very difficult to find system metrics that leaders and boards can relate to, and to find initiatives that those boards can engage in.
Most people go to work most mornings wanting to do a good job. The average doctor or nurse or manager or pharmacist, they don't want to fail, they want to succeed, they want to be proud of their work. If that work is set up in such a way that they may fail, they will feel bad about it, but they often can't change that context.
The hospital where I was working was implementing a new system, an electronic one, to communicate the reports from surgical procedures. And previously what would happen is the pathologist would come into the operating room, they'd look at the CAT scan, they'd look at the tumor, and they'd write down longhand the preliminary report. And then a final report would be issued that would be written and sent electronically. Well, there was a change in the process, which I didn't know about, in that the preliminary report was now going to be issued in a written format. So without any knowledge of this, I grabbed the chart, I looked at the report, I didn't see any signs or indication this was preliminary or there was anything else pending. I assumed it was the final report. And so wanting to plan that treatment with my patient, I went into the bedside and gathered the family and told them the good news, told them that it wasn't cancer, told them that she wouldn't need any further treatment and she'd be up and around in 2 days and she'd be off and life would be back to normal. Well, unfortunately, another report came 2 days later and she needed more treatment. It wasn't benign. And I had to tell her about that. She was outraged. How could this happen? You're telling me you have one report that says I don't need radiation treatment and there's another report 2 days later that I do? What's wrong with this system? What's wrong with you?
We're not talking about error-prone people, we're talking about error-prone organizations, error-prone workplaces, error-prone systems. And if we are to manage error properly, then we need to deal with these error traps.
Some organizations and circumstances are like this, highly vulnerable to error. Others have some measure of resistance. The aim is to reach this position, where resistance to error is part of normal life. So, what needs to be done?
The crucial part of error management is to identify the error traps by collecting data about near misses, free lessons, and identifying the workplace circumstances that seems to lure people into error. Removing those error traps is really the first stage of error management.
When you think about the cause of something, to just say, well, they gave the wrong injection, the person bled and they didn't save them, or whatever it was, there's a big story behind that. Now, the importance of that is that when you are trying to change things, it's no good, or it's not enough, to just simply go to somebody and say, well, you made a mistake, you've got to do better. You've got to look at all these other factors.
A critically important aspect of within patient safety is transitions in care. And we have led research here looking at safety during transitions from hospital to home and found patient safety problems that were much more prevalent than had been previously estimated. 1 in 5 patients, when they leave an acute care hospital, will experience an adverse event. Furthermore, a third of those adverse events are preventable, and another third are what we term ameliorable. They could have their severity reduced if simple things could be done to mitigate the severity of the problem.